everyone. We do have a lot of people in the waiting in the lobby. So we're letting people on in at this moment. We'll give people just another minute or two for the program to get everybody on in. Thank you, everybody, for joining us today. This is the Training and Education Committee meeting from the Medical Psilocybin Advisory Board. My name is Dr. Dominic Zerlo, and I'm the Director for the Center for Medical Cannabis and Psilocybin. My role here is just to help facilitate and to provide updates. And today the chair, well, not just today, but for long standing, the chair is Brenda Burgard. And so just as a reminder to everyone, this meeting is being recorded, so please remember to use appropriate language. I will put into the chat a couple of reminders and contact information. And with that, I'll turn it on over to you, Brenda.
Oh, thank you, Dominic. So, hey, welcome everybody. Thank you for coming to the training and education part for the psilocybin medical program here for the DOH. Really appreciate you all being here. To save a little time, we're not going to do formal introductions. So I'm going to read off the agenda here. If Jorge can bring that up, that would be great. And then I'll introduce Catherine Warnock with her presentation, and then spare a couple of maybe 15, 20 minutes to take questions afterwards. If for some reason we're going through this very quickly today, it's because I want to give Catherine plenty of time to present. So in today's meeting in the agenda, I'm Brenda Burgard again. I'm the chairperson for education and training for the Department of Health. And to begin, the core New Mexico competencies, and I'll just read through everything here. For fast track for licensed, trained, and certified practitioners participating in indigenous healers, supervisors, co-facilitators to be allowed to practice and after meeting standards and completing New Mexico program, and those who are currently in training in other states. So in other words, what that means, if you are in some kind of training in other states, you'll be able to take a little bit of extra training here in New Mexico to fulfill the core competencies that we are requiring here in New Mexico. Okay, to begin, training and certification structure. The framework includes teaching or supervision competencies, to be a teacher, not just a facilitator, and a 10-hour reciprocity track, previously trained professionals. And I added this in as optional add-on practicum refresher. That meaning that those of us who have not been practicing, but just need a refresher course, this is to be added on if you wanted to do actually practicum, and also to the education part, which would be about 10 hours. This is just, this is flexible. This is not written in stone. I just wanted to add that. Okay, so there'll be an optional supervisor pathway with advanced competencies and overnight and evaluation. I put a question mark here of hours and training program start to finish. So if you're brand new to all of this, we haven't really come to a decision on how many hours this will take in order for you to be licensed in practicing psilocybin. So without prior training and or certification, I'm thinking of 2 levels. This is all up for discussion of combining didactic education and supervision practicum and align it with other full course programs in the U.S. If there's time later in the meeting, we will discuss this. Otherwise, we'll push it to the next meeting if we have time. Okay, next, scroll up, please. Okay, this is just a little diagram. Here, the first bubble, we have meeting standards set by the DOH. And then from moving to the right is legacy training and education. Down there in the bottom is licensing and certification. And then we have the medical training and education. And then we have the core competencies and reciprocity. Okay, next. Okay, the core competency framework for medical psilocybin training and education in New Mexico. Okay, the purpose. This framework establishes the minimum competencies required for safe, ethical, and effective practice in regulated medical psilocybin program in New Mexico. It is designed to support facilitator licensing, must be resident of New Mexico, clinical service delivery, training program accreditation, and possible considerations. The CIIS, NAROPA, MAPS, Fluence Training, IPI, Intertrek, Synaptic Institute, Pradi, Añado de Vegetal, Santo Domingo, hope I'm pronouncing that right. Tribal consultation required for those. Therisville, Imperial College, London Center for Psychedelic Research, Synthesis Institute, and the BA of Brazil. Now, these are just some of the many, many, many places that are that we may consider for the program here in the Department of Health to incorporate here in New Mexico, because there are people from all over walks of life here in New Mexico that have trained in other countries as well. So I wanted to also include that into what we're trying to present here. The next is public safety and ethical integrity. Public safety, I cannot stress enough. In the last meeting with Nod's meeting, this was one of the main things that we were discussing at length, and it's paramount to everything, because safety is what we're trying to really get everybody to understand what that means. And there's a whole bunch of things that go with this. Integration with behavioral health systems in New Mexico is the next one. Okay, the New Mexico Psilocybin Reciprocity Competency Track for out-of-state certified licensed professionals. However, they will need to be residents of New Mexico in order to be part of the licensing. The purpose in this track provides a streamlined pathway, 10 hours plus, for professionals already trained in psychedelic facilitation or related fields to meet New Mexico's specific requirements, including state regulatory compliance, cultural humility in New Mexico communities, legacy and lineage and reciprocity integration, ethical and scope of practice alignment, safety and risk alignment. Eligible applicants, licensed mental health professionals, LPCC, LCSW, LMFT, etc. This falls under the umbrella of practitioners who are therapists, medical providers, MD, DO, NP, PA, RN, etc. Certified psychedelic facilitators who have trained from other states, Oregon and Colorado, are residents of New Mexico, pastoral, spiritual care providers, indigenous traditional practitioners with pathway recognition and flexibility. And I forgot to add end-of-life practitioners as well. Okay, let's move on to the next. Okay, teaching or supervision competency. To be a teacher, not just a facilitator. Expect experience in clinical supervision, adult education, and training delivery. Ability to assess competencies for DOH approval. Documenting psychedelic-related training plus hours. Building curriculum, teaching experience. Demonstrating cultural indigenous collaboration. Engaging with the DOH advisory process. A DOH-approved training program with a curriculum aligned to state competencies, safety protocols, and supervised practicum model. Programs must have approved curriculum. Instructors are tied to program approval, not just individual credential. A recognized professional or traditional credential, formal psychedelic training and practicum, real facilitation experience, teaching supervision skills, trauma-informed ethical competencies, cultural indigenous awareness, and affiliation with the DOH-approved program. Next. Okay, so I set these up into modules, and I want to encourage you all, if you need to go ahead and put questions in your text, and we can at least hold that until we can towards the end of the meeting. So, I know that, I'm trying to create a flow here, but I can't walk and chew gum and ride a, bicycle all at the same time. So Module 1, New Mexico legal and regulatory alignment, and we're looking at 2 hours there. And the content, the New Mexico Department of Health psilocybin rules, scope of practice distinctions, facilitator versus clinical provider, documentation and compliance with expectations, mandatory reporting laws, and competency demonstrates understanding of the New Mexico specific legal requirements and aligns existing practice with state scope of practice. Okay, Module 2 is legacy, lineage, and reciprocity. New Mexico focused. Hours are 3 hours. And again, these are just trying to get an idea of how many hours these will take, give and take, okay? We need to have historical lineage of psilocybin use, ethical considerations in modern practice, impacts of colonization and prohibition, includes Maria Sabina and R. Gordon Wasson, what happened there, the war on drugs, we all know what that is, and anything else that may be part of this content of the history. Applied competent development of refinement of reciprocity plan, including community reinvestment, access equity strategies, ethical representations of services. Competencies demonstrate cultural grounding and a non-extractive practice, and articulates personal and professional accountability. Module 3, Cultural Humility in New Mexico Communities. Hours or 2, content working with tribal and Pueblo communities, Hispano-Chicano populations, rural and underserved populations, language, trust, and access to barriers. Competencies, adapt care to local cultural contexts and demonstrate humility versus assumed competencies. Let's roll up a little bit more. And then we have a workforce pathways and I can't say it. You all know what I mean. For Native practitioners to support equity and inclusion. Creative alternative or parallel certification pathways for Native practitioners developed in collaboration with tribal governments. Allow for recognition of lived experience and traditional knowledge when voluntarily shared. Flexible training structures for tribal communities. Ensure participant in an opt-in or not assumed or required. Okay, Module 4. Okay, ethics, boundaries, and scope of alignment. Okay, hours or 2. Now, I know ethics is a big one, so we may have to add more hours to this. I'm not sure yet, but ethics is always one of the biggest things that us clinicians need to take at least, I believe, 12 hours within a 2-year time limit for that, so we can get our CEUs for that. So we're always doing ethics as far as that's concerned. So the content for that would be New Mexico specific ethical expectations, scope clarity across disciplines, clinical versus facilitator versus spiritual roles. That's pretty important. Power dynamics and client safety. Competencies, maintains appropriate boundaries, avoid scope drift or role confusion. So we have to know what our roles are and not have that blended too too much, because then we're hitting into ethics and boundaries there. So those need to be very structured. Okay, module 5, safety and risk alignment, bridging module. Hours are 1. So I know this is probably going to be more than just 1 hour, but for reasons for keeping a time limit on things during these meetings, we can always add or subtract more hours. The content here is New Mexico safety expectations, risk response protocols, referral networks within New Mexico. So that's a really important one. I think what we're going to be looking at, do we really need referrals from, physicians, or is this going to be what we presently have right now? This is a possibility. I know as a practitioner, I need to give referrals to psychiatrists to give, prescribe medicines, and to also do assessments as well. So we'll look at that more closely as time goes on. Let's see, the competencies for that aligns prior to training with New Mexico safety standards. Okay, now module 6, the practicum or weekend refresher optional. That's 6 to 8 hours. So that's going to take up a big chunk of our weekends. However, I feel that the practicum is where we do a refresher, because some of us have not been practicing for a while or have not really had the opportunity. So that is one of those things where I think it needs further discussion. And I think let's roll down further. Okay, now here's a supervision track that I decided to put in here, because I think supervision is one of those things that we really need to look at as well. Who will be qualifying as a supervisor. So advanced reciprocity for supervisors, an additional 6 hours. Module A will clinical and ethical supervision in psychedelic care. Hours are 2, supervision models, evaluating competency and readiness, managing ethical violations. Module B, advanced legacy and power dynamics. Let's see, that would be 2 hours, navigating authority, influence, and preventing exploitation and misconduct, and accountability and structures. Module C, evaluation and gatekeeping. That's 2 hours, competency, assessment tools, documentation, reporting, and remediation processes. Supervisor competencies demonstrates ability to assess facilitators' readiness and applies ethical oversight and accountability, integrates legacy and reciprocity into supervision, according to the New Mexico DOH. And I don't know if there's more. Is there more there? I think that's it. That's the end. And what I found in Dan's meeting this morning is that, okay, we're going to have some, I'm going to use his language, parking spots for some of these things. And also too, if there's been any blind spots in some of these, that we can also put into the education and training part. So now all of that has been said. I encourage you to put it in the chat if you have any questions. However, we're going to hold that for the end here, because I don't want to take up too much time here. So, Catherine, Ms. Warnock, are you ready to present your PowerPoint?
Yes, I still need to share my screen so I can figure that part out here.
Okay, let's give you a few minutes. Take a breath.
And while Catherine is doing that, just so everybody knows, I have put into the chat that all of that information that Brenda had just read through after the photo. For some reason, I can't get the photo to copy into the chat. So, but that way you can see what the different competencies and the timeline on that Brenda was reading off.
Okay.
And Catherine, if you can't do the share, I can share it for you and you can just tell me when to go to the next slide. Do you want to do
Okay,
that?
let me see if I can. I'm trying one more thing. If I can't make that work,
Okay.
let's try it. Let's see. Are you able to see this?
Yes, there it is.
Excellent. Okay, well, hello, everybody. Let me turn my camera on. There we go. Hello. So today I'm going to be talking essentially about developing a safe and effective psilocybin facilitator training here in New Mexico. I'm really grateful for the opportunity to present today. I was asked to do so mostly because I have been offering training already in the state for about 4 years now. I want to just speak to that slightly. The only reason that I have been offering training is because currently what is out there are these really long programs that cost $10,000 or such. And there was a lot of people just wanting some training around harm reduction. People are doing this work and have been doing this work for a long time. And I was asked essentially by various people, hey, can you just offer us some information around safety and some basics? Most of the trainings that I have been doing have been attended by people that are already doing this work. And they were just wanting to basically have community because working alone in this is probably not the safest option for people. And it's interesting because lately there has been people attending that are brand new. So I can see that there is a trend and things are shifting. And so today I'm going to talk a little bit about the training model that I've developed. I by no means have been telling people that if you take my training, then you can just you're ready to start doing this work immediately. That's not been the design of my training. It's more about taking what I've learned both from attending TheraPsil in Canada, as well as the work that I was doing experientially, and also following the scientific research, following the clinical models. I want to make it also really clear that I've not been doing any cultural appropriation. I don't say that I'm working ceremonially. I never have. I'm working clinically. And today what I plan to do is to review a little bit about the training model. I want to talk a little bit about the treatment framework for client care. I want to talk a little bit about some proposed practicum options for the state training program. And then obviously I'm here to suggest equitable and safe implementation in New Mexico. So what I'm really wanting to do here is just to provide some ideas for building a safe, ethical, and culturally aware state program. And thank you very much, Brenda, for inviting me to speak today. So who am I and who do I think I am having this presentation? I am a licensed professional clinical counselor in New Mexico, Colorado, and Texas. I was also licensed in Washington, but I've let that lapse, mostly because I have been focusing most of my efforts here in New Mexico. I do have a private practice in Las Cruces, New Mexico, Mariposa Counseling Center. And I have recently started a position of Director of Education for Psychedelic Assisted Therapy Association, PATA. They originated in 2021 in Oregon. Jason Burge is here today to support this and to maybe even answer some questions. I've got a slide or two in here about his model, which I think is an important thing to discuss in helping us to establish this program. And a big part of what PATA is trying to do is to offer standardized education across the nation so that as states become legalized, they have a place to land to start getting education and to start creating community and networking. I'm very excited to be a part of this. Some of you know that I have been secretary for Decriminalized Psychedelics New Mexico since last year. I also offer not only psychedelic assisted therapy as a facilitator, but also as an educational, from educational aspect as well. I'm trying to help people feel empowered to do this work safely. I've also had the benefit of being able to write a book and release a documentary around the clinical version of this work. What I focus on primarily is ethical and safe practices. I think it's important that practitioners are trained and that they are able to receive supervision. And I think it's really important that we focus on client preparation and integration frameworks, specifically using the clinical model. This is a medical model, and I think it's important that, we're setting things up accordingly. So I just want to quickly talk about what I think the core pillars of psilocybin facilitator training need to include. There's definitely the knowledge, right? We all need to understand the science, the psychology, what are altered states, what does all that mean? And not only the science behind it, the pharmacology, the also just understanding how this medicine works. We also need clinical skills. We need to know what preparation involves, what is integration, and how do we do that? And also, how do we facilitate in a way that it makes the most sense, following, again, the clinical model? Ethics are always important. It tells us what our boundaries are, how to keep people safe, how to do this work responsibly. And then I think experiential is also just as important as the others. Not only do I feel like everyone needs to have a relationship with the medicine, I also think that practicum is a great way to help people feel confident and learn how to do this work in a way that isn't just, trial and error, where people can have backup and assistance in learning how to do this work. And just really quickly, so if we follow all four of these pillars, the focus and the hope is that we have safe and effective facilitation. So now, before I go any further, I do want to talk about this model that PATA has put together that I think is really important for us to discuss and to become more aware of. I think we tend as a group to just kind of lump preparation and integration all in as one, but really there's areas in which we have both therapeutic and we have administrative preparation, as well as for integration. So administration is obviously kind of focusing on logistics, safety, compliance, where therapeutic is more the psychological, emotional, and clinical process. In Oregon, they're not allowed to actually use therapy. Even though it's called a therapy program, there's no allowance for therapeutic techniques of any kind. And so that's a big part of why prep and integration have been separated there, where there is administrative preparation, but there's no therapeutic preparation unless somebody's going to a counselor or to a therapist. So if you go to Oregon, you receive administrative prep, you get the experience, and you get integration from an administrative point of view, but you're not necessarily getting the therapy piece. That requires like another level, or them seeking additional care, whether that be some people are working with their therapist and then they're going to Oregon to get the experience. And then they have the pillows, both before and after, where they're actually getting the therapeutic experience. Here in New Mexico, it looks like I haven't really heard anybody discuss this, if they're going to be separate. It does sound, I've heard a little bit about offering like peer support guides, etc., to maybe help with the experience. But I think it's important that we're looking at this path here and understanding that there's two different kinds of prep and two different kinds of integration. In fact, using this model, some people who don't want to have anything to do with the experience can still offer the prep and the integration, while we have people on site that are actually doing the administrative prep integration and, of course, facilitating. So I think it's important that we're examining this framework and understanding what the differences are. I've been attending the other subcommittees, and I know they're talking already about how many sessions are going to be required for preparation, but I'm not really seeing the definitions or the teasing out between therapeutic preparation versus administrative preparation. Being that we're doing a medical model here in New Mexico, therapeutic prep and integration is important, and from what I understand, that is to be included in this program. But I do think it's really important that we're understanding that, there's different levels at which people can operate. So if somebody doesn't want to become a counselor, they can still participate by being a part of the experience and the administrative prep and integration. So I just wanted to kind of point that out. I've also got a couple of slides here that just distinguish what the difference is between administrative preparation and therapeutic preparation is. So for administrative, we're talking about documentation, informed consent, medical review and assessment, scheduling, reviewing of policies, procedures, expectations, as well as setting up the environment and having a safety plan. Therapeutic preparation is more about developing trust and the rapport, in setting your intentions, exploring history, themes, goals of this process. And then, of course, preparing for emotional and psychological experiences. A big part of this, which I believe I'll talk about later, is how ready are they psychologically for this experience? They might be ready administratively, they might okay, I made the time and I'm willing, I've got the schedule and I'm going to do this, but are they really ready for this experience psychologically, emotionally? These are things that I think as the, maybe in the counselor point of view, where the practitioners will be utilizing the therapeutic preparation to determine these types of things. And with respect to integration, the administrative aspects include, again, scheduling, documentation, coordinating with other providers, making sure that they have the appropriate supports or their matrix is sufficient and in place. Tracking outcomes. I know that the research subcommittee is doing a lot of work on collecting data. That would all be, under the administrative umbrella. But then therapeutically, it's more about processing insights. What are the, what are some new patterns and new perspectives that are coming up? How do you actually apply those into behavioral change? Making sure that they have continued psychological support around their growth and around the changes that are happening. And then, of course, reinforcing self-awareness and these new understandings. So now I'm going to focus a little bit on how I deliver my trainings. I do a didactic instruction for the first day. And then on the second day, there's an experiential learning component. And so for the didactic portion, I am focusing on the science, the pharmacology, the legal, what are the regulations, what are the contraindications, and what are the risks. We talk about clinical skill development, how do you prepare clients, how do you screen them, what does non-directive facilitation mean, and then how to help people integrate. The second day of my training is an experiential where half the people choose to dose and half will choose to guide. And this will allow participants to have their own experience in a safe way. Some people want to experience this medicine, and I think it's important that you do experience the medicine prior to guiding clients to fully understand this, what this medicine is. I mean, here's the thing, for a doctor, you don't really have to have had cancer to understand how chemo works and to offer chemo to a client. You can still do the same thing with psilocybin, but I will tell you that if you understand this medicine personally, it's going to make you much, much better at the work you're doing with and helping to guide the client. And I think that having a place where people can experience the medicine for themselves is important. And I do believe when I talk about practicum later, I think this is going to be an important part of what we need to be offering practitioners. It's also on the second day, I'm offering people a supervised experience of guiding others. What does that look like and feel like, and how, and then they get to do it, but knowing they have backup and knowing they're not doing it by themselves. Also being able to observe multiple client sessions. So when when I have my second day, I might have like three practitioners are dosing, and then we may have 4 or 5 guides. So now we get to experience multiple different experiences because no 2 psilocybin journeys for anybody are the same. It's good to have, different examples to experience so that it can build confidence and expertise. And then, of course, I always offer an online integration after the training. So whoever dosed gets integration. That's a key and important part of the experience. And usually they allow the other class members to attend that integration so that they can also get firsthand experience on what integration looks like. So just a little bit more on the content that I include. I think it's important that we're talking about the history and the cultural context of this medicine, the difference, between clinical and ceremonial use, what the history has shown around the suppression of research and how research has emerged again. And so grateful for that happening. And then, of course, it's important to understand and be aware of ethics around traditional medicine origins. Then, of course, moving on to the science and pharmacology, I make sure people understand what, they know what psilocybin is, how it interacts with the serotonin receptors, what is the default mode network, what is ego dissolution, and how that impacts the experience. Also, I focus on dosing ranges and the pharmacokinetics around that. I also talk about the legal and regulatory landscape, that it is a federally Scheduled I drug, that a lot of states are trying to decriminalize or implement these types of regulated programs, and what the responsibilities are within the medical frameworks. I also make sure to take time to talk about risk awareness and participant screening. Not everybody is going to be well suited for this experience. We want to make sure that there's psychological stability, that they're ready for this experience, and that they don't have any physical health exclusions. I think that the participant subcommittee is doing a great job of establishing what those exclusions are. And so I've been able to be a part of that and see the amazing work that's happening in all these subcommittees. It's also important to assess the medication that they're taking. There are medications that will interfere or dampen the experience. Antidepressants, antipsychotics, anti-anxiety medications, benzos, opiates. It's interesting because I'm starting to see a lot of stuff around semaglutides that's coming up. I was able to identify 4 years ago that semaglutides significantly interfere with the experience. These are all important things to consider. And some of these things will literally rule somebody out if they're taking certain things. It's just not safe for them to be doing this type of treatment. And then, of course, always having a medical consultation whenever appropriate. If somebody has a severe cardiovascular or if they have diabetes, I want to make sure that, they get medical clearance. Is their diabetes being managed? Is it not? If they have severe cardiovascular, chances are they're probably not going to get a doctor to give a clearance. It depends. I'm not a doctor. I don't claim to be. So I think it is important that we're utilizing that avenue when appropriate and necessary. I also utilize www.psychedelicinteraction.com. Kristen Spear, she is a pharmacist up in Denver who created this website. that allows you to type in whatever medications you're taking. Then it will give you any contraindications. It'll basically give you information about those medications, because I'm not a doctor. I'm not the one going to tell anybody what, anything about their medicine. So I will refer to this website, which will give a printout, and then they can then schedule a consult with that pharmacist for more information, because that's not, again, knowing what my scope of practice is, I'm not a doctor. All right, further risk awareness and participant screening. We're also looking for certain conditions that are contraindicated. I already mentioned some of them. And then, of course, managing any risk, making sure that participants are aware of what challenging experiences might happen, setting realistic expectations, and in making sure that they have appropriate support systems in their matrix. When they leave, are they going back to a domestic violence situation? Well, that's not going to be a good appropriate treatment for them if they're not going to be safe when they get home. Examining these things are really, really important. So we also spend quite a bit of time talking about the stages of psilocybin-assisted therapy, how preparation, the session itself, and then the integration, how they're all important. And then, of course, with making sure that you're building the rapport with them during preparation. You do the assessment. You create intentions. You manage expectations. Establishing setting, and matrix. These are all important things. During the session, we want to make sure that we're offering a non-directive facilitation. Planting seeds is not okay. It's not our job to tell clients what they're experiencing. Providing a supportive presence and being able to monitor the experience is what's important. And then also providing that containment, a psychological and emotional containment. Of course, integration. We know that integration is critical. Processing the insights and the emotions are really important, translating those experiences into meaningful change, and then getting the continued support necessary. Doing the medicine by itself might provide therapeutic outcomes. It might, but preparation and integration are what's going to align everything towards the positive outcomes. So one of the things that I forgot to mention on the PATA slide that talked about the process, the experience itself is not psilocybin assisted therapy. That's just, having a journey. Psilocybin assisted therapy includes preparation and integration. It's a process. It's a process that's going to take a minimum of, if it's being done with proper time in between, a minimum of 4 weeks, but it could be like 8 weeks, depending on how long it takes for you to prepare, and integration, by the way, can happen for months, maybe even years sometimes. So it's a minimum, I would say a minimum of 3 to 4 weeks, but this process could be years long. It's not going to be this really fast, quick thing. We need to be taking time for the preparation and the integration. Okay, so moving forward to the facilitation model, I'm very much, again, follow the clinical model, which is to support participants on their inner process, not direct their experience. So things that are important to include as core principles, we want to encourage curiosity, accept all the emotions that come up, maintain calm and being attentive, avoiding interpretation or providing any advice. And then, of course, we want to support that they have autonomy and making meaning of their experience from what as they see it, not as we see it as facilitators. Also, a big part of what I believe in the work that I do is creating intentions for a journey. I would say that this has been the single most important piece of preparation and integration and the experience itself is to help participants define their intentions. By creating intentions that they identify during the preparation process, it allows almost for the healing to start. It's almost like they're beginning to think about and process, what is it that I'm wanting from this experience? And if we're doing it well, we don't even need the list by the time you get to the experience, because they already know, they're already locked and loaded what the things are that they want to work on. Do you have to have intentions? No. But for therapeutic outcomes, I would say that this is the most important piece, is in preparation and in integration, is to have been reflecting on the areas that you want to heal from. And when the medicine takes hold, these things are already present, and we know that psilocybin is an amplifier, and it will literally just amplify what you've been thinking about and focusing on for the weeks prior. I also will feed participants what is on their list. If, for example, if they are having a hard time with something, let's just say they're going through a loop where they're experiencing something over and over and over again. And when that happens, usually after the third time, it's not valuable anymore. It's just like a repetitive experience. I usually tell clients that when that happens, let me know. We'll probably have you switch positions, switch the song, go to the restroom, do something. And then I will feed them one of their intentions that they prepared. And that will then take them back in a different direction. I have found that using these intentions has also been the best way to assess the experience in the integration phase. In the beginning of doing this work, a lot of people would come to me and say, well, my intention is to be open to the medicine. And I thought, wow, that's great. But what I've learned is, yeah, I think everyone needs to have that intention. Like, that should already be an intention. If it's not an intention, then they're not ready for this experience. That's part of being ready. I have found that when people just have that as their intention, they come through it going, yeah, okay, I got some stuff, but they're not able to actually see the profound implications of the experience, as well as if they had a list of intentions that we can now go through with them and they can see the shifts for themselves. And I'm going to tell you that 9 times out of 10, people come through and 90% of their list has been addressed or no longer is a thing. I find that intentions are critical. So intentions provide direction without imposing control on the experience, because they created those intentions. I may have helped them formulate them, but they are their intentions, and we're using the words that they provide. I don't change the wording. I literally read it exactly as is to help them focus on their experience. Without intentions, they may have an amazing experience, very much like an Alice in Wonderland going down a rabbit hole. With intentions, I know they're going to work on the things they want to work on, and the therapeutic outcomes will be dramatically improved as a result. It's also important to teach people how to manage challenging experiences. When it's not uncommon for people to be experiencing anxiety, fear, or panic, especially during the induction phase. It can also be that they're having to relive something in order to work through it. Emotional release and trauma activation are definitely possible. People can be confused and disoriented as well. So it's important that facilitators know, like, when to have them lean in to what they're experiencing versus when are we going to try to, help them kind of come out and then go back in a different direction. It's also really important as facilitators that we maintain a calm, grounded presence. I've seen it over and over again where practitioners get very uncomfortable when somebody starts to emote. And it's, or even if they're getting angry and they're starting to release, maybe they're starting to scream. It's important to help people feel comfortable that this is part of their process that they need to go through, and providing reassurance and orientation to the client to help them focus on the things that they want to focus on. Supporting the participant and staying with the experience so that they can get the therapeutic outcomes. Growth requires it requires us to sometimes go through challenge. And these experiences are not always very pleasant. Sometimes they are hard. But the outcomes, if you stick with it and you're providing the safety and the space they need in the container, they can get through it with very, very positive outcomes, having actually worked through that trauma or that fear. And then, of course, we always want to adjust the environment when needed. It's not unusual for somebody to say something about the environment that's bothering them, the temperature, the lighting. And it's important as facilitators that we're helping to address that. One of the things I do want to say about the way in which I operate, the way in which I facilitate, is I tell people that I want them to let me take care of them. Lean into the experience and allow me to do all the things. If they don't like the song on their playlist, let me change it for them. If they need more water, I will go get it for them. I have had many, many people after their journeys come to me and say that the most therapeutic part of their experience was the fact that they didn't have to worry about anything and that there was somebody there caring for them and taking care of every need they had. If they need to use the restroom, I'm going to walk them there. I'm not going to just say, oh, just give them, direct them to the restroom. No, I'm literally going to have them put their hands on my shoulders and I'm walking them to the restroom. Many clients have said that having somebody take care of them teaches them to take care of themselves, especially when they're under the neuroplasticity of the medicine and they're allowing somebody to take care of them. Chances are when they leave, they're going to allow others in a little bit more in helping to take care of themselves, and hopefully they're going to prioritize taking care of themselves as well. Integration is extremely important, and it's interesting because a lot of people come to me and they say, well, what exactly is integration? And integration is essentially counseling. When we have a client that has an insight, we're helping them to apply that into their life. That's what we do as counselors. Usually they come to counseling because they're recognizing something big in their life. For example, I'm realizing that my husband isn't good for me and I need to examine this relationship and see if this is the right thing for me. Well, a counselor is there to allow them the safety to explore what they need to explore, to be able to apply these new insights that they're having. We're doing the same exact thing with integration, except the insights happened during the experience, right? They're these big insights where when ego goes offline, we're making connections that we don't normally make. And so it's the role of the facilitator when it comes to integration is to help them to just to help them reflect on what's coming up for them without imposing our own meaning, but allowing them to make meaning out of what they experienced themselves. We're helping to support their emotional processing, translating insights into action. Well, how do I apply this now that I understand this new thing about my mother? How do I deal with her? How do I work with her? So what are some integration practices? Structured reflection and discussion, identifying patterns and new perspectives, and supporting behavioral change. And then there's ongoing support. Insights can unfold over time. I've known people that can have insights a year after their journey. It's because maybe there was a piece of it that, not necessarily that they forgot, but they just didn't focus on. But then a year later, something happens and, oh my gosh, I understand it now. So I think follow-up sessions can reinforce outcomes. and having continued support improves safety and effectiveness. I've worked with a client before for a couple months, and then I'll hear from them like 3 months later because, oh, I have to process a new part of my experience. So I think it's important that as facilitators, we're providing that safety and that space, that ongoing relationship, even if it's a few months later, because there might be something new that comes up that's related to their journey that still needs to be processed. So as I say here, participants often process insights for weeks after the session, which is why integration is so essential. I had many people say to me after a journey, oh my gosh, I've had all these amazing insights, and now I have to go home and just apply these to where nothing else has changed or different. How do I take this new meaning and understanding that I have and apply it in a world where no one else gets it? That can actually cause people harm if they're not integrating. So integration is key and critical. So now I wanted to switch gears and talk a little bit about practicum. I'm super excited about being able to offer practicum. This is new. This is something that doesn't really exist out there. I mean, I know some of these programs offer a little bit of practicum, like maybe a journey or two. What I want to be able to do is I want to be able to offer like a week-long training of practicum if people want it, so they can get multiple experiences with multiple people, not just like one person that I guided. I think that it's going to be remarkable for New Mexico to have practicums, and I hope all other states end up following suit. So the purpose of practicum is to help bridge the knowledge and the clinical application. So to be able to use it in a real-time setting, to develop competency, and to ensure safe and ethical facilitation. So as I've already mentioned before, it's important that people have like a supervised facilitation experience, that they be allowed to have a journey on their own to experience it, that they be able to observe other sessions, other clients, and then be able to have structured feedback and integration of their learning. So I would like to offer two options for practicum. One of them, which might be, one thing I saw, Brenda, you said 6 to 8 hours for practicum. That's really only one experience. I would actually recommend more than that. I would recommend at least 2 experiences. I guess it depends on what we're talking about. Are we talking about people that have already been doing this for a while, or are we talking about people that are brand new to this? If they're brand new to this, then I think they're going to need like a week-long practicum. That's just my opinion. But I do think this option here, option 1, is where you dose and you guide. So on one day, you would dose, and other facilitators would guide you. And then on another day, it's switched so that you then get to experience what it's like to guide. This will give people, the structure they need to both participate, observe, and then practice facilitation. This will help people engage in their own healing work, develop a relationship with the medicine, understand the internal experience, and then also build confidence in facilitation. So I see this being like a 2-day experience, maybe not even back to back. Maybe it's like one weekend, one person doses, and then maybe the next weekend, it gets switched.
That sounds really reasonable. Thank you. I just wanted to chime in there just to make sure that I'm not being, I am paying attention here, but yeah, I think, from start to finish, more hours for people need that. So yeah, absolutely do. Yeah, great.
Thanks. So the second option is the immersive experience that I was talking about. It's a multiple day practicum, and it's focused on real clients. So what I would really like to do when I offer this is I want to be able to have clients receive this experience at low or no cost. And then we actually, because they know they're going to be in a practicum experience where people are learning, so there's more flexibility, and this way we can actually offer treatment to people here in New Mexico. like I said, at either low or no cost, where we have facilitators come, and what ideally, the way I see it is it would be like maybe a week long where before the practicum begins, you are assigned 2 clients that you're going to help prepare, probably online, unless we can do it in person, just depending logistically how that would work. But then you would come and you would guide either like Monday, Wednesday, or Tuesday, Thursday. And then other facilitators are also guiding. So you end up with 10 to 16 client journeys that you've experienced over the 4 days. You're responsible for 2 of them, primarily, but you have backup and you're being supported through the entire experience. And you get to essentially facilitate with a cohort where everybody is, like I said, responsible for 2 clients. So by the end, if we've got 8 people, then we've got 16 clients. This gives people a wide range of experiences and exposure that's going to help build confidence, that's going to help build expertise. And then maybe the last day, Friday, is like, an integration day. Or maybe it's too much to do in 1 week. Maybe we split it up over 2 weeks. Maybe we come for a couple days. I don't know yet exactly what that's going to look like. But I do think that this is going to be the fastest and best way for us to get people feeling competent, especially since we've got to get things moving fast in this state. So this is something that I think that we should require for people that have no experience guiding, so that they can feel by the end of this immersive experience, they are feeling much more comfortable and confident doing this work. So now switching gears a little bit to what are some of the things that I think we need to be considering with respect to this program. I do think we need to have access pathways for individuals without licenses, without degrees. I saw on the list that doesn't look like that's in there, so I don't know if that's something that will be added. But I think that if somebody has to go through an extensive training program, they can, at a minimum, do the facilitation, right? The admin, the experience, and then the administrative, and then maybe we have the counselor doing the psychological pieces on the other ends. I also think we want to make sure that we're including pueblos, tribes, nations. And my idea around this, which I know it's just my idea, and I don't know if anybody really cares what my idea is, but I have this platform, so I'm going to go ahead and share it. I actually think we should provide a number of facilitator slots based on population for these communities. So if, and then they'll have the elders decide who gets those positions, because they're not going to have education and licenses and degrees. They've been doing this their whole life in a very different way. And that doesn't make them any less suited for this work. And I think that if we just did a per capita thing, like if you have this much population, you get this number of positions that the elders will assign. But then in order to maintain their licensure, they have to maintain CEs just like the rest of us, right? They would still have to attend ethics trainings and all the other things that we're all going to have to do on a routine basis. And then I like seeing that this is already you're already talking about this, is recognizing people that do have prior experience, grandfathering individuals that have training and certifications. Of course, we need to have New Mexico specific trainings and jurisprudence around the laws of New Mexico. I do think it's important that we are including ethics and professional responsibility. I want to make sure that people understand what their scope of practice is. Like, for example, I'm not a doctor. I don't claim to be a doctor, and I don't really want to be doing things that are perceived as though I think I know, what a doctor would say or do. I think it's important that we're all keeping clear on what our boundaries are and our scopes of practice. Wanting to make sure that we're protecting participants. They're in vulnerable states. I had heard about somebody who during a journey, they were telling people, oh, we'll work on that later, which was their way of getting additional business. And I think that's completely wrong. We shouldn't be planting any seeds during a journey. We don't want to make people dependent on us. Just because I planted a seed during their journey, telling them that they're going to need me later. That's not okay. It's important that we focus on harm reduction and safety, screening, risk awareness, helping people prepare and supporting them properly through the process, making sure there's ongoing integration and follow-up care. So even though there are integration sessions, individual sessions that are being offered afterwards, I hope that the state program will offer maybe integration, like online integration, like maybe weekly, where anybody who has attended or received this treatment can attend integrations, maybe at low or no cost, maybe covered by insurance. Having an ongoing integration system where people can get what they need, even if it's months after their treatment. Obviously, I'm a big proponent of experiential training. That's why I think that practicum is going to be so important. I also am a big believer that everyone needs to understand what this medicine is. So I think understanding altered states does improve safety and effectiveness. So in closing, again, just thank you so much for allowing me to speak. I just think that well-trained facilitators are the primary safeguard in any psilocybin program. Thank you very much.
Thank you, Catherine. That was a superb presentation. Thank you so much for that. Now we're going to go back to, there were a lot of questions in the chat. Some of them were answered by Dominic already. I'm going to kind of popcorn this a little bit. Does anyone have any questions for the Department of Health here, or Catherine or myself, or Dominic? If you wanted to raise your hand, we'll do a raised hand first, and then we'll do a chat, and we'll go back and forth like that.
All right, and I see Lita Fatemi's hand up. Dr. Fatemi, I have enabled your mic.
Thank you so much, Catherine. That was fantastic. Thank you so much for just awesome presentation. One of the things that we have just never really discussed or touched on is the recommendation regarding the frequency of which a person is recommended to do the medicine journey. You know, in our work, what we talk about is not more than every 3 to 6 months, so that you have time for, maybe, you know, even less frequent than that. But that has come up in the past, and I think it's an important point to touch on. I also have had, you know, people who will do a psilocybin journey for the first time. They're like, oh my God, this is so amazing to feel like, you know, more complete. And then they think that doing more psychedelics gives them more healing. And then they'll go to a retreat center in South America, and they've really been tapped into escapism after that, and into psychosis, and on and on and on. And so I think it is very important as educators to talk about that, the frequency of the journey itself, especially with macrodosing. Thank you so much for all the work you've put into this. Appreciate you all.
Thank you, Dr. Fatemi. Yeah, I think there's a lot that that we still need to discuss about what happens, you know, during and after journey. And I think preparation for the client, if you're really educating your client first off about it, about these journeys, that yes, you know, how are people going to pursue that afterwards? That if you do educate your clients well, that you're doing, you know, you're doing the best job you can. And, you know, if people choose to do that afterwards, That's kind of a gray area, but, caution with safety around this and assessments and doing the due diligence as a therapist or a medical provider. I think that's where we need to really hone in on the education piece when we're talking with our clients. Next, I want to kind of jump into the chat here. The first one we have up here is Luita Kirkorian, and she was asking, what is the timeline for various educational programs to begin applying for approval? And this has not yet been determined. It is part of what these meetings are working through. The requirements and application process at the current pace of progress. Late summer, early fall is most likely before applications are opened and the regulations have to be promulgated. Okay, next, does anybody have a hand raised for another question here?
And again, as a reminder too, to raise your hand, there's an icon at the top with a hand that says raise. It might be on the left or right, depending on different people's systems, but should just have a hand that says raise.
Okay, I'll go to the next in the chat. It's from Kate Hawk. I appreciate this is moving quickly and have concerns about needing more training, especially for ethics and safety. Colorado had a 25-hour program for experienced practitioners that gave time for discussion as well as information. I found it valuable even after extensive practice and teaching, etc. That's valuable, yes. Of course, as far as the ethics is concerned, as I said in the beginning of the meeting today, when I was reading the document, for us clinicians, we usually have a 12-hour ethics that we need to meet. So I think having the ethics part of that in this program would qualify for some or all. We could do the 12-hour requirement for the licensure, and we as clinicians, we have to do 40 hours of CEUs within a 2-year time frame to keep up our licensure. So I just want to kind of reiterate that a little bit. Let's see, anyone else have their hand raised?
It looks like next we've got Chris Piskuski. And Chris, I have allowed your mic. You can talk when ready.
Hi, Brenda.
Oh.
Hi, everyone.
Hey, Chris.
Good to talk to you all. So it sounds like that this committee is committed to offering reciprocity to people who have trained in Colorado and Oregon. So is that going to be maybe a baseline for our training here in New Mexico as far as hours? And there is about a 25-hour difference between the two programs. So would Oregon have to make those hours up, or would we have a baseline starting with Oregon's kind of hours and curriculum?
Good question, Chris. Thank you for that. The way I see it is that they have already been incorporated in our system, and being a resident as well, because I don't know how long you have to be a resident. I think it's 6 months in New Mexico, and that's just the way our licenses are set up. In order to practice here in New Mexico, you have to be a resident. And however, if you've been trained in another state or country for that matter, you would, and you're certified or licensed in another state or country, if you come here and you're a resident here in New Mexico and you want to be licensed, you just need to go through the short program for people that have already been trained in psilocybin or psychedelics. So that, in my mind, that's how it would work. Well, let's say hypothetically, we say everyone that is licensed and has gone through a program somewhere else, here in New Mexico, you would have to take the 15 hours of that extra training to practice here in New Mexico. So that's hypothetically speaking, that's what we're kind of looking at in order. So you're not spending thousands and thousands of dollars on getting trained and all those hours that you've already put into it. Here in New Mexico, we want to meet this kind of fast track into practicing here. Now, from start to finish, we really haven't come to a conclusion from that. People, let's say you want to get taught here in New Mexico. As far as Colorado and Oregon go, if you get trained here in New Mexico, I have no idea if you could take what you've learned here in New Mexico and go to Colorado or Oregon and have that transfer, because they came first, but we're trying to design something here that's for New Mexico and New Mexico people that are practicing here as clinicians. So I hope that answered your question.
I think in a roundabout way, I guess what I'm saying is it sounds like we want to offer reciprocity for people who have been trained as a facilitator in Oregon and Colorado. Is that correct?
Yes, we want to be able to accept people from other states or other countries that want to practice here. So that's why we're looking at more of bringing in that reciprocity piece in, and that they would only have to take an additional learning process, in other words, in order to practice here in New Mexico.
Do you mind if I keep going on this thread, or do we have other
no,
people?
go ahead, keep going.
Okay.
Yeah.
Okay, so if we are going to offer reciprocity, then it kind of stands to reason that we have a similar training model as either Oregon or Colorado, but they do vary slightly, and one of them takes pretty significant more time to get. And so I'm curious if we've kind of, if you all have picked one that we're going to model it after, or if there's thought to how that's going to work.
Okay, Dominic, I think could answer that a lot better than I can.
Thank you, Brenda, and thank you, Chris. It's a good question. And just to kind of clarify, one thing to remember is different licensures do have different requirements. So that's a part of why anybody who has a particular licensure will still have to follow their requirements with regard to that licensure. As to the reciprocity, as was discussed in a much earlier meeting, what we're really looking at is we want to ensure people are still trained in New Mexico. And that's where the idea that Brenda had presented, showing that anybody who has been trained in those other states would then be able to take sort of a refresher course, I think is how Brenda said it, but essentially doing some modules that are specific to New Mexico to ensure that any gaps that might be there are covered. As to new programs, that's still being developed, and how exactly that will work, we're not quite sure yet, but has been noted in the chat. Dr. Fatemi put in a comment about competency, and that's a part of what we've talked about. And like Ellen has about how the competencies will be evaluated, we do have to determine that at this point. And one of the things we've also talked about is if you go through the programs in either Colorado or in Oregon, you have to go through the entire program. So you have to meet all of those hours. That may not actually necessarily be appropriate depending on the experience or the licensure of the different individuals going through here. So we're also looking at what would we want to do to ensure that we actually have a really good educational program for those clinicians and facilitators. So we haven't actually determined that. And the reciprocity in the beginning is really a starting point to get the program going. There most likely will be an end point on that where we would no longer accept somebody who has been trained elsewhere, that they would have to go through a program certified by New Mexico to be able to be to do this, but we would still grandfather those people who had already been in there. So this is really that starting point to ensure that we have practitioners and facilitators, within it. But the point you bring up about the discrepancy between the Colorado requirements and the Oregon requirements is a good one. And that is actually true with a lot of different licensures in different states, where they will have vastly different requirements for maintaining or even obtaining that licensure. What we really need to decide, though, is while we look at those programs and see what is appropriate, what's going to be good, and we've been talking with a lot of different people who actually are facilitating lots of those programs and people who are doing that here, including quite a few people who are on this meeting, so that we can figure out what is actually going to be the best program educationally, and not just going with saying, oh, well, Colorado has done this, we're just going to adopt it, or Oregon has done this, we're just going to adopt it. We want to ensure that it's a good program. That may not be the point for the very beginning, but what we develop over time. And in the very beginning, allowing for that reciprocity, because we have many people who are here in New Mexico who have gotten that training and will be excellent facilitators and clinicians. And so we don't want to cause them additional burden by saying, go and take it another course that's going to cost you $8,000 or $10,000 or however much it costs to go through it. We want you to be able to practice that you've already learned. So those are some good questions. And as we dive into the details in this committee about the different areas and sections and competencies, that's some of what we have to determine. But in the initial stage, yes, that reciprocity will be there. It may be time limited, and that time frame hasn't been determined yet. And some of it will depend on how much, what the demand here is in New Mexico. So just wanted I hope that helps. There's still a lot to be done in this area, especially. And I probably just made it even more confusing.
Well, thank
Okay,
you,
I
Chris.
see a
Thank
thumbs
you,
up from Chris.
Yeah,
I'll take that as a...
Okay. Thank you, Dominic. Thank you so much for the explanation. Yeah, sometimes I'm not that, I don't have that already on the tongue here to explain. I just wanted to go through some of the chats, and then we'll go through a couple of chats, and then we'll answer some more raised hands here. So Maya says, is there any place for role for people in New Mexico model for those who do not hold a clinical medical license? And then Vincent, I echo this question. I am finishing up training in Colorado, and there is a clinical and non-clinical licensure pathways. Will that be offered in New Mexico for those who do not have a medical or mental health degree? And then Gregory said that part, thank you for voicing that experiential knowledge for providers. So basically, we really are not looking at right now as like a co-facilitator pathway yet. That's for further discussion. But we've got to remember that this is the medical psilocybin program here, and that if you do not have a medical degree or a mental health degree, but you have an alternative type of certification, we'll have to look at that a little bit more closely. But for right now, as far as initiating the rollout here, is that the people that will be practicing will be people that are licensed in mental health or medical, as far as I know. Okay, next, raised hand.
All right, we've got Jen Clemente. And Jen, I've enabled your mic. and unmute whenever you're ready. Yeah, there you go.
Okay, thanks so much. So in my mind, I'm trying to think about like the design of the application to become a facilitator, and I'm thinking about all the sort of fields and variables you're going to have to look at. So it'll be interesting when when it gets to that time, and maybe that could be another session just to look at how do you apply and sort of what do you how do you fill out that application, and if it's open-ended, if it's closed, opened, and whatnot. But my question really comes to spiritual dimensions of training and care. Catherine, in your excellent presentation, which was really inclusive and really considered so many things, I did notice that the word spirituality and spiritual was missing. And I don't know if that was by design or if that was something that, that you're thinking like, okay, so the chaplain or spiritual care provider who may be as a part of that care team that would be their area of specialization. But I really do think, and in the presentation I gave, I guess, a month ago, I touched on this topic a little bit about how I thought it was important, at least for anybody on the care team, to have some awareness of spiritual dimensions of care, and sort of that depth psychology angle as well, anything that goes into transpersonal or having an understanding of the spiritual experience and spiritual emergency that can come through as well, spiritual emergence and emergency. So I'm wondering if you would be so kind as to touch on that, and your thoughts on kind of how spirituality fits in training.
Well, yeah, thank you for pointing that out. It was actually by design, just because, again, trying to kind of stay in my scope of practice, generally speaking. However, I will say you cannot remove spirituality from this experience. Like, that's just not an option, right? It is a spiritual experience, and that we do need training around that. I believe the CIIS guidelines for practitioners states in there that we need to have spiritual intelligence, which I actually should be more like spiritual competence, not so much intelligence, because I don't think you need to know every possible spirituality to do this work. But I agree with you that there does need to be some education around spirituality and how that comes into play. And I think this is something we need to definitely have more conversations around.
Great, thank you so much. And I look forward to having them with you.
And I just wanted to remind everyone that in the document that I wrote up in our first meeting, that does include pastors and spiritual healers in this as well. So just to make a point of that. And of course, if you are having a spiritual experience that, therapists also need that training, and that will be also included in the training as well, and what to expect.
I mean, I also think, though, just to say real quickly, I think that as counselors, that's what we're trained to do, right? We're trained to honor a client's experience, regardless of whether it's spiritual, emotional, mental. It's almost like that's part of what we do. When somebody shows up and they're telling us about, their perception of what they're experiencing, it's not our place ever to tell them, no, that's not right. Or, our job is to hold a container for them to explore whatever it is that they're experiencing. And I feel like spirituality is no different. So I feel like we're already sort of trained to accept whatever anybody brings to the experience, and especially in a psychedelic experience where there's so much creativity, right? There's creatures on trains showing up asking if somebody wants cake. Like, there's things happening that aren't logical, that don't make sense. And it's all about allowing for the person to have that full experience, whether it's mental, emotional, or spiritual. So, I mean, I think that as far as like our responsibility as a facilitator is to allow whatever they're experiencing to be their experience.
Well, thank you both for that. It's really important to have these discussions. Okay, going back to the chat, I'm going to kind of skip over some of them because some of them have already been answered with Chris's question about certification in other states from Kate Hawk, and Dominic posted the New Mexico resource for clinicians in the statute for licensing, because Maya had a question about that. So I'm going to skip down here. Okay, so Eileen Brewer had some concerns. She says, I have serious concerns about requiring this model. One of the beautiful things about New Mexico's law is that it's meant to be expansive. We are starting with treating just 4 areas: PTSD, depression, SUD, and end-of-life care. But the 5th bullet point was other conditions as approved. This board has decided to go with just 4 areas to start appropriately, since more could be overwhelming. However, very quickly, New Mexico does intend to expand, and the first area that makes sense in chronic pain treatment. There is a vast amount of evidence for psychedelics as treatments for chronic pain, and a desperate need since there is very little safe, effective treatment for chronic pain. However, the treatment protocols being developed for psychedelics for chronic pain are mostly very much medical, with the medicine used like you would any other medicine, and very much more frequently than you would use it for depression or PTSD. Creating requirements for this program that will be difficult to change later will further distance this desperate population from accessing treatment that may save their lives. Requirements like mental and administration preparation and integration before and after every single administration session will make this treatment inaccessible for someone who needs to take 1 to 2 grams every 5 days, or for someone who wants to microdose, or for someone who may need to titrate up or down. Oregon has already encountered this challenge and needed to reconsider the burdensome requirements. In addition, end-of-life care already includes pain care. If we tell someone seeking end-of-life care that they need to go through this lengthy and burdensome process, it may create a barrier to access for people who don't need it all and just want relief from pain and a broader view on death. While these are strongly recommended for people treating difficult mental health conditions, I don't know if this is a good idea to codify it as a requirement for every single patient in every single circumstance. In addition, if providers are not aware of the developing protocols for pain treatment, those who have read in the media that psychedelics help treat pain may seek a PAT model experience, get an appropriate treatment for their needs, and then wind up more hopeless than the treatment fails. Pain is only one reason. Consider this. There are likely dozens I don't know about. So very, very, very good points here, Eileen. Yes, as a clinician, I would say that the majority of the clients that I have right now have chronic pain. And I think we will be looking at this as well. I don't know what you have to say about that, Dominic, but it's one thing that I guess we need to look at. So who else has their hand raised? Who's next?
Next, we've got Shane McDaniel. And Shane, I have enabled your mic.
Can you hear me?
Yep.
Good, that means it's working. All right. So I hate to just keep hashing out this reciprocity issue, but as a currently certified integration coach that went through one of the expensive programs already, would and talking about grandfathering in people with Colorado or Oregon certifications, my certification isn't out of Oregon or Colorado. I mean, I can treat people all over the United States, all over the world already, as long as they, want to hire me. My certification program didn't have anything to do with the Oregon requirements or the Colorado requirements. So that would be a separate reciprocity issue than somebody who just had met the Colorado requirements or the Oregon requirements, or am I wrong?
As I see it, what we were talking about earlier is grandfathering people in that have already been through a certification process or licensing process that included their education and grandfathering in. What we're looking at right now is adding our New Mexico reciprocity program, which will be very short requirement hours. So I understand it sounds like you're able to do this in many places. But here in New Mexico, we would require, like, for instance, we would require you to do, I don't know what it would be. Right now, I'm looking at 10 hours, but let's say it'll be like 25 hours for you to practice here in New Mexico. Is that correct, Dominic?
So I mean, we haven't determined exactly what that module will
Right.
look like. So, I mean, that's a part of some of the continued discussions, but I do need to be clear. It has to be an approved program. So it has to be a program that's already been approved. And we can utilize other states because they are regulatory agencies as that we can say they have done some of that due diligence. So it has to be a program that has already been approved by one of those other states that has this. So if it's just a program that's out there because they offer psilocybin training, but has not been approved by a regulatory agency, that's not going to be something we're going to be able to accept. As far as that, Vincent, the programs in both Colorado and Oregon do list down what programs, what educational programs they have already approved. And part of the reason behind this is because there have been educational programs that have actually been problematic. And so it has to have gone through an approval process. And here in the beginning of the program, quite frankly, we just won't have the resources to go through to vet every single possible program. And so we're using the fact that they have already been vetted. For example, in Oregon, they have to actually get approved, not just by their health department, but also by their higher education department. And so they've already gone through that kind of a review process. And so what we're saying is if it's gone through that type of process, through those types of regulatory agencies, we will accept that as a reciprocal requirement, because that's very similar to what we do with if you've been reading in the news about the various healthcare compacts, that's very similar with what we do there. For other programs, we are going to be setting up the requirements that they have. There'll be applications that will be out there for programs to apply to, but we're not going to be able, there's just not the resources and ability to say somebody got a certification from this program that has not been approved by one of the other states. We are not at that point going to be able to say, here, we can do this. Now, we can say we would set up potentially a review of those requirements, and they would need to meet the requirements New Mexico sets up. And we could do that, on that, but realize that will take a lot of time and resources. And I'm not sure that we would be able to do so in a reasonable fashion, because there are a lot of programs out there that offer training, and it may or may not be as extensive as some of the other programs, but they haven't necessarily been reviewed. And so we have to ensure there is that review process. I hope that makes sense.
Yeah. I just, like I said, I would hate to find out that, 6 months of training I went through and paid, it wasn't $10,000 like was mentioned earlier, but it wasn't cheap. But if, I guess with anything, it's buyer beware, right? If I did my due diligence or didn't do my due diligence and find out that, you guys aren't going to accept it, that's on me. But I do appreciate that these conversations are going on, and I very much appreciate the discussion around how important integration is in the speaker earlier. It's just, I have so much gratitude for what's going on right now, guys. It's just unbelievable, that this has come where this nation has came in the last year or two regarding psychedelics is astonishing. Much respect,
Thank-
guys.
Thank you, Shane. Well, for the sake of some of the chats are fairly redundant because I think we've answered quite a bit. So what I will do is I'll go in and select some that were that weren't answered yet. But in the meantime, we could take another hand raise and I'll then I'll jump back to the chat here.
All right. Next, we've got Deb Thorne. And Deb, I've enabled your mic. You can unmute when you're ready.
Hello, hello. It's great to be here. Really good topic today. And I did have a few questions. I already put them in the chat, but I know it was pretty lengthy, so I wanted to just voice it. For those of you that don't know me, my name is Dr. Deb Thorne. I'm the founder and medical director of Soul Trip and clinical director of Medicina del Sol in Las Cruces. I guess the thing I wanted to know more than with Catherine's presentation, I wanted to know, is psilocybin outside of the medical program already descheduled for training purposes, especially for those of us waiting to offer this in a legal way? Can anyone answer that?
Hi, Deb. This is Dominic. At this point in time, it has not been descheduled. And so while people are talking about that, that is not something that unless somebody becomes a patient in the program, they would not be able legally to go through that process in New Mexico at this time.
Okay. So I'm just curious how so many programs that are now involved with the medical program are able to provide that experiential part. How is that being done legally?
So Deb, right now, the program does not have any permits, licenses, or anything else, not even set up on regulation. So we do not have the ability to, and we don't have law enforcement abilities, for example, to move forward with regard to people who are who may be utilizing illicitly. And what we have said before in other meetings, I've said it in interviews, is that if individuals feel that things are happening illicitly, they should be reporting it to law enforcement. That is the same process, by the way, that occurred when medical cannabis first became legal. The department did not have the ability to turn around and arrest or do any of that sort of thing if someone was utilizing illicitly. We stay on the side of, as the medical program gets set up, how do we help and facilitate with regard to the medication within the program itself? And so if somebody feels that somebody is doing something illicit, that is actually between them and their licensing board and or law enforcement. That's not something that we as a program can do. We only have authority over those who will be at the time when they are actually licensed or permitted.
So if someone has been practicing in a way that, well, what we call the underground, and they do apply to the program, would they be accepted?
That needs to be determined. And currently, right now, we're not even at the point where we have those regulations. However, it could be problematic if somebody has any kind of criminal history or anything else, because those are going to be some of the details that the different committees actually are going to have to determine. Will that be allowed for individuals who are then permitted to do this practice? For example, when medical cannabis first started and with the producers, individuals who had a criminal record and had arrests and or charges were not actually allowed to be able to be cultivators, distributors in the very beginning of the program. And so that's something, however, that was not addressed in the statute. And as we move forward with the regulations, it is one of the items that needs to be addressed. We just have not gotten there yet.
Okay, well, I'm glad to know that that is on the docket and that it will be, I guess, thoroughly discussed and put in place when the time comes. But and I am in no way putting down the underground. There are some incredible facilitators out there and have been for decades. But a lot of them did receive a lot of mentorship. And I think that's a big part of the training. And, just harm reduction is so, so important. So with our medical program, I think that is definitely in order. And, those are things that we're definitely going to cover. And I'm happy to see that. But yeah, I wondered if, for training purposes, let's say there is a group that's offering training for facilitators and prescribers, would there be allowances for those participants in the state of New Mexico to receive an experiential, so they don't have to go to Oregon or Colorado to receive that? Is that
It's a
something?
great question, Deb. And currently, with the way the law is currently written, we do have our legal team who is actually looking at that, because from the plain language of the law, it does not seem to allow it. Again, without somebody actually having one of the diagnoses. And so that is a good question. And it may be something that in the beginning of the program, we're not able to offer, but perhaps down the road.
So if a training program wanted to offer that, would we just submit something to DOH to see if we get approval?
Well, again, right now, we haven't even set up the requirements for those applications, so I can't
Okay.
really answer that until those are set up.
Okay. All right. Thank you for answering those questions.
Of course.
Thank you, Deb. Those are great questions. And again, caution, as far as the medical cannabis goes, there were many people who were growing and supplying many people underground. And as that started to develop, more growers came forward and started growing just as things started to become legalized for medical use. So again, looking at how the medical cannabis program started off, it's not as cut and dry as we all think it would be, but there are definitely, there's micrologists that are know how to grow mushrooms, and that was from the propagation committee. And so there's a lot of things that in the meantime everybody has to obey the law and go with that. So these are really good questions. So I just wanted to see if there was anything else in the chat here that has not been answered yet. Okay, here's one, Ellen, who is covering their liability insurance. So that has come up quite a bit in other meetings and meetings that I've had. Right now, clinicians and other specialists do have insurance, but right now, to specialize in getting covered for psilocybin, that has not been approached yet. It's just like anything else. If if you're doing something nefarious with your license, you could potentially have that pulled if your insurance company, you've been doing something illegally, or if you've been doing harm for that matter. So I just wanted to answer that question. There's another question by Tay Davis. How have people been doing this, doing it for years? It's very interesting. Oh, I wanted to read, first of all, let me back up here. Yeah, I think the question there is more like, yeah, we're just really sticking to the medical model here, and not really looking at what other people have been doing for underground for years. So we really need to stick to that topic. I can't answer that. People have been doing this for years on their own or treating others. That's a whole nother can of worms to go through. There's anyone else? Okay, who's next to be for a question with a raised hand here?
Next, we've got James Brown. And James, I've enabled your mic.
And James, just before you start, I do want to do a time check. We do only have 5 minutes remaining in the meeting. So I know there's a couple of people with their hands up. If you can please make it brief and just so we can still end on time. Thank you.
Again, no problem, Dominic. And Brenda, thank you for sharing this, and great presentation, Catherine. Thank you so much for the information and everything you shared. One comment is just that I put in the comments there is personal bias. I think we definitely need a section on personal bias of the facilitator to make people aware of that while you're sitting in that space in that container. Thank you so much.
Thank you, James. Okay, from just to save some time, let's attend to the raised hands at this moment. And I apologize, we didn't get to all the questions in the chat. Okay, who's next?
So I think I'm next. I came just a little bit late, and it looked like we were going over like a supplemental course that New Mexico may use. Is that something that's already been decided by this committee, or are we going to get a chance to kind of review that? And if so, or will it be sent out with the next invitation for the next committee meeting?
Good question, Chris. I think we're still trying to figure that out. How many hours for reciprocity and how many hours for a full program. So I think we're going to discuss that even more so maybe next meeting. Who's next with a raised hand?
All right.
Here?
Yeah, last we've got Desba, and Desba, I've enabled your mic.
Yep. Hi, can you hear me?
Yeah.
Okay, just really quickly, just for the sake of definitions and for the sake of the DOH recommendations in medical psilocybin, I believe that we are only working with medical dosages and not working with what are considered microdosing, because I know that kind of came up in one of the comments. These are for dosages for sitting, not for microdoses, not for that use, not for recreational use. It's medical psilocybin only. Thank you. Great presentations.
Correct. That's correct, Despa. Thank you for mentioning that. Okay, I think this we got 2 minutes left. So thank you all for coming and sharing. This was really a very good meeting. And your input is vital to helping us make decisions for the Department of Health for psilocybin medical use. I think, in the next meeting, we'll have possibly another presenter. I'm not sure yet. Haven't crossed that bridge yet. So thank you all for coming, and thank you all for participating in this. And I do apologize if I didn't get to everyone in the chat for our questions. Thank you.
And thank you, everybody. Hope you all have a great Friday and weekend. We'll see you all again soon.